A very good morning, good evening to one and all present today. We welcome you to the second episode of the Dermatology webinar series hosted by the Autoimmune Academy. The topic for today's webinar is clinical and laboratory diagnosis of autoimmune blistering skin disease. Similar to our previous sessions, we will have two speakers presenting in our webinar. Towards the end, we will also host a panel discussion where all your questions will be answered live by the speakers. So in case you have any questions during the webinar, please type them in the chat box available. Any unanswered questions will be relayed to the speakers directly, and all your responses will be received via email. Without further ado, it is my pleasure to introduce you to the first speaker, Dr. Animesh Sinha. Dr. Sinha is a professor in the Dermatology Department of University at Buffalo, New York. He obtained his MD and PhD degrees from the University of Alberta. His subspecialty training in dermatology was completed at Yale University New Haven Hospital. As a board-certified dermatologist, his professional goals are aimed at bridging the bench to bedside gap. His research is focused on understanding the genetic and immunological basis for complex skin disorders. He has published over 150 peer-reviewed articles and received numerous honors and awards for his academic activities. Thank you, Dr. Sinha, for presenting at our webinar. I will now pass it over to you to begin your presentation.
Hello, I'm Animesh Sinha. I'm coming to you from the Department of Dermatology at the University at Buffalo. And I'll be presenting today in our session on clinical and laboratory diagnosis of autoimmune blistering diseases. I'll specifically be talking to you about disease presentation, pathophysiology, and some clinical concerns and considerations. I have no disclosures to announce. And I thought I would structure the talk into 4 sections. We'll first talk about some basic review of skin structure and function in human autoimmunity. And then I'll spend some time on the Pemphigus group of diseases, followed by the Pemphigoid group of diseases, and then end with some clinical considerations and concerns as we look to the future. So let's talk about the skin and autoimmunity. So just by way of review, the skin is a very complex organ, and it can basically be divided into 3 main subregions: the epidermis, the topmost region, the dermis that lies just below, and the hypodermis, which is not pictured here, but lies below that, which has the subcutaneous fat and blood vessels and so forth. The epidermis itself is a complex area with a number of skin layers. And these skin cells, or keratinocytes, are attached tightly to each other by structures called desmosomes, or tight junctions. And the basal layer, bottom layer of keratinocytes, also attaches to the underlying basement membrane through structures called the hemidesmosomes. They attach the bottom part of these cells to the underlying layers and into the dermal-epidermal junction. So the skin is the largest human organ, and it has several functions in identity, sensation, biosynthesis, but also very important in protection. It provides, of course, an anatomical barrier, but also very important in immune defense. Now, the immune system is, of course, very vast and complex, as is needed to battle all the pathogenic universe, viruses, bacteria, fungi, other pathogens, and maybe even neoplastic cells that arise within ourselves. But there's a central tenet and paradox of the immune system. How can such a complex and comprehensive system that recognizes this entire antigenic universe distinguish between those things that are foreign versus our own proteins, our self? So normally, of course, we do not recognize or mount a strong immune response to our own self-tissues, and that's a process called self-tolerance. There are several mechanisms that have been developed to maintain self-tolerance, but the full understanding of self-tolerance remains to be elucidated. Nonetheless, when these mechanisms break down, and they can break down, that leads us towards autoimmunity. And we can consider autoimmunity as the failure of an organism to recognize its own constituent parts as self, which then results in an immune response against its own tissues and cells. And it's been reported that there are over 80 to 100 human autoimmune diseases affecting probably 7 to 10% of the population with autoimmune disease, and 15 to 20% have some autoreactivity that we can detect. Autoimmune disease collectively are just behind cardiovascular disease, neck and neck with neoplastic disease or cancer as the second or third leading cause of morbidity and mortality, with a tremendous economic healthcare burden of over $100 billion annual cost to the U.S. healthcare system. So a very serious set of diseases. And it's been difficult to understand and manage these diseases because the etiology is complex or multifactorial. They're both genetic and environmental factors that work together to dysregulate the immune system, leading to autoimmune disease. And although we have some idea of these factors leading to disease, most of the genetic and environmental elements are still being worked out and yet to be elucidated in the vast majority of autoimmune diseases. You can classify autoimmune disease in a number of ways. They can be organ-specific or systemic diseases, and also by the ultimate mechanism of tissue damage. It could be cellular or T-cell based, or humoral or antibody or autoantibody based, or a combination. And of course, there are autoimmune diseases across all our organ systems, including the skin, and we'll be talking about pemphigus and pemphigoid. So let's talk about the pemphigus diseases first. So pemphigus and pemphigoid fall under the umbrella of autoimmune blistering disorders. The main distinction between the pemphigus and pemphigoid groups is the level of the split or the blister. So in the pemphigus group, the blister, the split, is intraepidermal, within the epidermis, the top layer of the skin. And in the pemphigoid group, the split is just below the epidermal level, so subepidermal. And that leads to different clinical presentations, which we'll get into. Now, the prototypical disease within the pemphigus group is pemphigus vulgaris, or PV. And this is a potentially life-threatening autoimmune blistering skin disease characterized by intraepithelial, and we'll talk about suprabasal, just above the basal layer of keratinocytes in the epidermis, characterized by acantholysis, or a loss of cell-cell adhesion. The primary lesion is a flaccid bullae, typically 1 to 10 centimeters, that filled with clear fluid on an erythematous base sometimes. Although we often don't see the bullae themselves because the lesions are within the epidermis. They are thin and friable and often shear off, so just left seeing erosions. Some other things that can be helpful clinically are the Nikolsky sign. Direct Nikolsky sign is induced by rubbing on normal appearing skin, and then a blister erosion can arise, or an indirect Nikolsky skin where can push on the edge of an existing lesion, and that extends the margin of the lesion. And these signs can be helpful in making the diagnosis of pemphigus and indicate that the pathology is in the epidermis rather than the dermis. The pathology is linked to the presence of autoantibodies that target certain desmosomal proteins. And remember, the desmosomes are key structures that are important, tight junctions that are important in maintaining cell-cell adhesion and epidermal integrity. So antibodies, of course, are produced by B lymphocytes and are secreted into the bloodstream. And they are Y-shaped proteins with a heavy chain and a light chain. And the business end, the binding sites are very specific for their unique target antigens. And the key targets, as I said, in Pemphigus vulgaris are within the desmosomes. And this is on the bottom left is a light microscopy figure of keratinocytes. And you can see the desmosomes a little bit if you look very hard as these little spiky things that connect the desmosomes. That's because of a technical artifactual reason for when we do the tissues, but it brings out the desmosomes that are these spiky connections between the keratinocytes. And on the right, you see a electron micrograph with two different keratinocytes that are then attached in two places at these desmosomes, these electron dense areas, zipper-like fashion. The desmosome is complex and has many proteins. We'll talk about many of these proteins in the context of the upcoming conditions we'll talk about. In Pemphigus vulgaris, the primary targets are desmoglein 3 and 1. So key proteins that are important components of this desmosomal structure or desmosomal plaque that is so important in maintaining cell-cell adhesion. Clinically, Pemphigus vulgaris most commonly presents with lesions in the oral mucosa, not always, but most typically. And here you see some examples. And again, most often, the mucosal lesions extend to other cutaneous surfaces. And again, you often don't see intact blisters, but patients often present with these extensive erosions where the blisters have sheared off. And so the lesions can bleed easily and are often weeping and crusting. And here you see some more examples. So it can be very extensive at times and therefore can even be life-threatening as we discussed. So in terms of the presentation, about a third of patients present and have mucosal lesions only. About almost 2/3 have mucocutaneous lesions at some point in their history. So they have both oral or other mucosal surface lesions and then other non-mucosal cutaneous lesions. And a small percentage have only presented with cutaneous lesions without oral or other mucosal lesions. There can be unusual presentations. So can be some vegetative lesions on the scalp, surrounding nail pathology, scarring lesions, and inverse lesions for example, in the axilla, the groin, and anogenital regions. So in terms of pathology, as I mentioned, it's an intraepidermal split. So here you see an H&E image, and you see the split is just above the basal layer of keratinocytes, giving this characteristic tombstone and row of tombstone picture. And so you see most of the epidermis come off here. And typically you want to take a biopsy at the edge of the blister. And here are some examples here. And Dr. Grover will go review this further in her presentation. Another key to diagnosis is immunofluorescence. So you can do direct immunofluorescence on tissues obtained from a pemphigus patient and their lesions. And you can come with a secondary fluorescently labeled antibody that detects IgG. And you see this chicken wire appearance where the immunoreactants are lit up by the secondary antibody, and they're surrounding the keratinocytes, indicating that there's antibodies attaching to the keratinocyte surface. Also, there can be diagnostic help from indirect immunofluorescence, and that's where you take patient serum and stain monkey esophagus tissues, and then come with, again, a secondary fluorescently labeled antibody, and again, you can see this chicken wire appearance, and that shows that there are antibodies directed against skin epidermal proteins in the blood of the patient that you're testing. And Dr. Grover, again, will review this more extensively in her talk. Also, very useful is ELISA testing, or enzyme-linked immunosorbent assay, developed by Autoimmune and a couple other companies. And basically here, if you remember immunology, on a tissue plate, you can lay down the target antigen of interest. In this case, will be desmoglein 3 and 1. Take patient serum, come with a secondary antibody that's linked to an enzyme, and then a substrate is added, and you get a colorimetric assay so that you can confirm the presence of autoantibodies to desmoglein 3 and 1 in this case, and quantitate them. And Autoimmune has a nice ELISA test for this that's been FDA cleared. So let's move on to the other entities within the Pemphigus group. So Pemphigus foliaceus is a similar disease to PV, except the split is higher in the epidermis. It's subcorneal, just above the top layer of the epidermis, in contrast to Pemphigus vulgaris, which, if you remember, was suprabasilar, just above the bottom or basal layer of the epidermis. And here you get more thin and superficial blisters and erosions, can be weeping and crusting again, and they have this cornflake-like appearance often. Mucosal lesions are rare, and here the autoantigen target is desmoglein 1, not desmoglein 3 and 1, just 1. Phogos selvagum. This is an endemic form of Pemphigus foliaceus. And the term translates to wildfire in Portuguese. It's endemic in South and Central America. It's been linked to bites of the black flies. And again, the autoantigenic target is desmoglein 1. IgA pemphigus. Here, typically the antibodies for the pemphigus group of diseases is IgG, particularly IgG4 subclass. But here there's a variant where you have the IgA subclass, a different constant region of immunoglobulins. Lesions are often annular, and mucosal lesions are rare and often has a little bit of a milder course than IgG pemphigus. There are two types of IgA pemphigus, a subcorneal pustular dermatosis type, and there the target is desmocolin 1, and an intraepidermal neutrophilic type, IEN, where the targets are desmoglein 1, 3, and seems like another transmembrane protein that's still being worked out. The difference is that in the first type, the SPD type, the pustules are subcorneal, as the term implies, and in the intraepidermal neutrophilic type, the pustules are within the entire epidermis. I just want to touch on perineoplastic pemphigus. This is a almost near complete fatal disorder, over 90% of mortality, that's been linked to lymphoproliferative disorders, particularly lymphomas and leukemias. It has a number of different clinical presentations, a Pemphigus vulgaris-like, a Pemphigoid-like, an erythema multiforme-like, a graft versus host-like, a lichen planus-like. And so mucous membranes are usually initially involved, and then going on to other mucosal and non-mucosal surfaces. A number of autoantigenic targets have been identified: desmoglein 3, 1, endoplakin, periplakin, desmoplakin 1, 2, bullous pemphigoid antigens, BP230, which we'll be talking about in a minute, plectin, and A2ML1 protease inhibitors. So complex disease and etiology with a broad range of targets. So let's go on to the Pemphigoid group of diseases. So remember, the main difference is that in the Pemphigoid group, the split is subepidermal versus intraepidermal in the Pemphigus group, and the prototypical Pemphigoid disease is bullous pemphigoid, or BP. And again, as I said, this is an inflammatory autoimmune blistering disease where the split is just below the epidermis, subepidermal, versus in pemphigus where it's intraepidermal, suprabasilar. And because the split is subepidermal, the lesions and the blisters are more tense than in the pemphigus groups. They tend to form particularly on the flexor surfaces of the arms, legs. And here you see some examples of these tense blisters. They can shear off as well, but often you see tense intact blisters. And often there's a phase of, and it often precedes the blisters or can be exclusive in itself, of erythematous urticarial pruritic plaques. And the pruritus can be quite extensive. So you just see these plaques, and here you see urticarial plaques as well as a tense blister here. If you do, in terms of immunofluorescence, you'll see that the immunoreactants, the antibodies, are targeted not throughout the epidermis in this chicken wire fashion as you see in pemphigus, but all along the dermal epidermal junction. And the targets are bullous pemphigoid antigen 1 or BP230, bullous pemphigoid antigen 2 or BP180, and also more recently identified with the pemphigoid group is laminin gamma 1 or P200. So here in this schematic, you can see the three main targets of the pemphigoid group, BP 230, BP 180, in the localized more to the hemidesmosome structures that are important in linking the basal keratinocytes to the underlying basement membrane and laminin gamma 1 here. Let's talk about a couple other entities in the pemphigoid group. Mucous membrane pemphigoid is now become the term of choice. There were a few different entities that now fall under that umbrella, including cicatricial or sarine pemphigoid, ocular pemphigoid or oculocicatricial pemphigoid, both of which are very severe forms and can be difficult to treat. But in general, these are the MMP group is the affects, as its name says, the mucous membranes, the mouth, and then the eyes are most commonly affected, but can affect other mucosal surfaces as well. And a number of different autogenic antigens have been, autoantigenic targets have been identified. BP180, BP230, integrin alpha 6 beta 4, laminin 332, and type 7 collagen. So here you see some examples in the oral mucosa, ocular sites, genital sites. Herpes gestationis. This is basically just pemphigoid during pregnancy and often begins with a pruritic papular eruption around the umbilicus, particularly in the second and third trimesters, more often than the first trimester. There's no association with herpes. Just historically, the term herpes was applied to anything blistering, and later we, of course, differentiate between infectious causes of herpes virus and autoimmune and other types of blistering. The autoantigenic targets in herpes gestationis are the same as for bullous pemphigoid. Linear IgA disease, again, the IgA subclass of autoantibodies is at work here, and it is can occur in adults, but especially seen in children around the perineum or perioral areas. Oral lesions are common. The autoantigenic targets are still being worked out, and there are a number of them. But the key difference is that the Ig subtype is related to the IgA subclass rather than IgG subclass. Now, here's a subepidermal blistering disorder that is not in the pemphigoid group, but it is targets collagen 7, and this is epidermal lysis bullosa acquisita, or EBA. So, so the activity of the autoantibodies here is below, targeting collagen 7, below the hemidesmosome. The lesions often occur in areas of minor trauma, especially on the dorsal aspects of hands and feet, and typically heal with scars and hyperpigmentation. And here you see some examples of that. On immunofluorescence, you cannot distinguish EBA from both pemphigoid on direct immunofluorescence because the staining occurs right at the basement membrane zone in this fashion here in the top images. If you split the skin with, treat the skin with sodium chloride and split the skin, the epidermis from the dermis, you'll see in EBA that the immunoreactivity is at the floor of the blister, and in BP, a pemphigoid group, it's at the roof of the blister, indicating that the immunoreactivity is below the dermal epidermal junction in EBA, and here in BP it's above. It's just at the hemidesmosome. And Dr. Grover will be going over this again more extensively. So let me end by putting this into a little bit of clinical context and talk about where we're at and some future considerations. So, of course, we all want to manage these patients. It's not easy to diagnose or monitor or manage patients with blistering disorders because the elusiveness of autoimmune diseases and our continuing evolving understanding of their etiology and pathogenesis, and that their natural history, which waxes and wanes and is variable between patients. And also, we have to understand that to treat disease, a number of factors should be considered. Drugs must be effective at reducing autoantibodies and antibody synthesis ultimately. Remember that the IgG half-life is about 21 days. And as the disease progresses, T and B cell repertoires expand, leading to more epitope expansion and escalation that can extend the disease. So in the pre-steroid era, mortality was extremely high, 50% at 2 years and over 85% at 5 years. Even with the widespread use of steroids starting in the 50s and 60s, mortality remained high at about 50% at 5 years, mostly from the complications of the steroids themselves. And now the mortality is much reduced to probably around 5 or maybe up to 10 percent in 5 years. And that's still too high, much better, but still too high. So we are continuing to evolve in our ability to manage and treat patients. I just want to take a look at the arc of how we've approached treatment in these diseases. So, of course, there's general immunosuppression with steroids and now non-steroidal immunosuppressives like Cellcept or Imuran and others. Because these are Ig-mediated diseases, people have also focused on eliminating or reducing immunoglobulin. So intravenous immunoglobulin therapies have been used. More recently, there's been attention on FcRn blockade. These are inhibitors of key molecules that help immunoglobulin stay in circulation. So if those are blocked, the rationale is that there'll be reduction in the immunoglobulins in circulation. And just immunoabsorption, just taking blood out from a patient and absorbing out the immunoglobulin and then putting the blood components back in. You've all, I'm sure, have heard of more recently rituximab and B-cell targeted therapy. So rituximab, of course, targets the anti-CD20 marker on B cells. And there is now also some promise for BTK or BAFF inhibitors, both molecules involved in B cell function. And most recently, and ultimately, we want to get to a place where we have antigen-specific therapies. So you might have heard of CAR T cells, chimeric antigenic T cells have been transformed to direct killer T cells to tumor targets. And now that has been also in a twist being used to target autoantigen-specific B cells. And that therapy is just being developed now. And ultimately, we want to get more specificity by targeting just the aberrant disease-relevant B and T cell clones. And so there's still active work in that area that will, I'm sure, continue to go on. But here's where we're at. There's not a single autoimmune blistering disorder for which we have a cure. In fact, there's not a single autoimmune disease for which we really have a cure. So we still need to better understand the natural history of disease and disease mechanism. The diagnosis of autoimmune blistering disorders is often significantly delayed. Work from our own group and as also seen by others is that there's a year or more wait from the development of first symptoms to accurate diagnosis. And so that really reflects on a number of factors, including the widespread or the lack of widespread use of and knowledge about diagnostic tests for these conditions. And it continues to remain the case that tracking the disease-associated autoantibodies is not routinely conducted, maybe in certain larger academic investigational research centers, but still, I believe that ultimately the frequent assessment of disease-associated autoantibodies will be a requirement for monitoring disease activity, and characterizing and predicting the occurrence of disease flares and response to treatment, and ultimately personalizing disease management. Because remember, these diseases wax and wane like most autoimmune diseases, and each individual patient has their own course and their own particular response to a given therapy or therapies. So at this point, I'd like to turn it over to a video of one of my patients, Lisa Ann Krutzek, who really has had a remarkable journey, and she's been very generous to share this. And during her presentation, she'll articulate some of these clinical concerns and challenges that she's faced in the course of her disease. So I think we'll turn it over to the video now.
Hi, my name is Lisa Ann, and I am someone who has a rare skin blistering disease. I was working full time. At the time when I got sick, I was actually working at an RV dealership. And then one day I woke up and I had a sore throat. Went to my regular doctor. He looked in my mouth. He looked in my throat and he went, "Oh, herpes." And I'm like, "What? I have never had herpes." And he's like, "Well, let's do the blood test and find out." And of course, me, like 80% of the rest of the population, has herpes simplex in their bloodstream. A few weeks later, I now have no skin underneath what's called a belly apron. And all of a sudden that was always wet. And I felt underneath there and it was all raw. Now my underarms are completely raw also. I have yet to actually physically see a blister. Okay, so I don't even realize that this is blister. This is just no skin and it's weeping and I'm freaking out. There's no two ways around this. I'm freaking out. I don't know what's happening with my skin. So he says, "Let's try to get you an appointment with either a rheumatologist or an infectious diseases guy." So I go into him and I literally do this. I literally bring my hands above my head so that he can see that everything underneath my arms is raw. And I said, "Fix me." To this day, that bothers me. Because if you had known me before PV, before this blistering disease, you would know that I never needed anybody to fix things. 2 weeks later, I go back into his office, and it's worse. Of course, at this point, I have no skin on my lips. I have no skin under my arms. I have no skin under my boobs, under my belly apron. I have little open wounds all over my body. And so the entire crown of my head was also all blistered up and weeping. This doctor comes in and he looks at me very seriously and he says, "I realize that you asked me to fix you. And I can't. Because I don't know what this is. I do know that it's not infectious. So I'm going to send you to a dermatologist because if anyone's going to know how to at least get your skin to stop weeping, it will be a dermatologist. And if I don't get you to somebody who can stop that, you're not going to make it." October 12th, I get an appointment with a dermatologist. The PA, her name was Mary, walked in, took one look at me, put her finger up and said, "Hold on 1 minute." And she went back out in the hallway. She came back in. She said, "I need to do a biopsy. Is that okay?" I said, "Of course, feel free, whatever you need." I put my hands up in the air. She was able to get a biopsy underneath my arm. And she said, she literally looked me in the eyes and said, "I think I know what's wrong with you, but I've only seen it in textbooks." And then she's like, "Look, I'm going to be honest with you. This is completely out of our league. And we need you to get an appointment with this doctor up at UV named Dr. Sinha." Up until this point, I had been seen by at least 7 doctors. It took over 7 months. I had lost over 70 pounds. Finally getting in to see Dr. Sinha and Dr. Seifert was a completely and utterly different experience than everything that I had done before. And at one point, I was literally praying that it was just HIV. The preliminary test results were that it was Pemphigus vulgaris. He came in and he sat down next to me and very calmly explained that even though they needed to do another biopsy to make sure that the diagnostic tests were absolutely correct, but that I was going to be okay. Reassured me that there was a future. If this can reach the doctors and the practitioners and the PAs and the pharmaceutical companies and the pharmacists and the people who help diagnose these things faster. 7 months, 7 doctors, and over 70 pounds is way too many 7s. And not being treated like a person, but a number on a computer screen is actually harder to deal with than 60 milligrams of prednisone every day.
Okay, so so as you can see, that's a very powerful video and gives you an appreciation for the sometimes tortuous path that patients have to take to get diagnosed and get their disease under control. So, so I want to conclude by just saying that I think we have come a long ways in understanding and managing the blistering disorders. But I think in the future, we want to continue to improve with our ability to manage and treat patients, and that will depend on continuing emergence of platforms for diagnostics, particularly those that are rapid and multiplexed and as accurate as possible, and the companion diagnostics with it. And just a couple examples in our own lab, and there are a couple other groups. we've developed doing some multiplexed proteomics. So we are able to not just look at one antigen or at a time with, say, an ELISA, we're able to look at multiple targets. This is a blow up of a glass slide that has 48 arrays in a 4 by 12 grid, and each of those arrays is a 12 by 12 grid, and we can lay down different antigens in triplicate usually, and then put a drop of serum from patient or control on each one of those 48 arrays. And so you can see we can very rapidly get information at a much larger scale than we could in the past. And Euroimmune has also been developing multiplexed assays on the immunofluorescent platform when they're multi-parametric biochip mosaic. I believe Dr. Grover will also discuss this a little bit more. And so where we're heading towards is a future where we are going to be able to track disease activity more accurately and more personally, and maybe ultimately with all that information include, artificial intelligence algorithms that help us more quickly and more decisively identify and confirm diagnosis in patients, and then track their disease and personalize their treatment. So I will leave it there. Thank you very much. It's been my pleasure to be with you today. And please type any questions into the chat box. Thank you.
Thank you very much for your wonderful presentation, Dr. Sinha. We sincerely hope Lisa Ann is doing well and is in remission. Now, I would like to introduce our second speaker for this webinar, Dr. Raminder Grover. Dr. Grover is the laboratory director at Buettner Laboratories in Buffalo, New York. Her area of interest and expertise include diagnosis of autoimmune bulbous and connective tissue diseases. She specializes in direct immunofluorescence biopsy studies, indirect immunofluorescence assays, and ELISAs for the diagnosis of autoimmune skin and mucous membrane diseases. She is a diplomat of the American Board of Medical Microbiology and is a volunteer faculty at the Department of Dermatology at SUNY Buffalo. Thank you so much, Dr. Grover. I will now pass it over to you to begin your presentation.
Thank you, Aishu and Euroimmune, for the invite to discuss the diagnosis of autoimmune bullous diseases. And thank you, everyone, for being here today. So I'm going to start sharing my slides. So I will be talking about the diagnostic aspects of autoimmune bullous diseases. The diagnosis of this group of rare but potentially lethal and disabling diseases has come a long way since Dr. Beutner and his colleagues established, standardized, and implemented the immunofluorescence assays that we still use today. In fact, the first evidence that a blistering disease could be caused by autoantibodies was provided right here at the University of Buffalo by Dr. Beutner and Dr. Jordan in 1964. They demonstrated the binding of IgG in sera of Pemphigus patients to the epidermal cell surface. And their first report, a demonstration of skin antibodies in sera of Pemphigus vulgaris patients by indirect immunofluorescence staining, has become a citation classic. It has 885 citations so far. So after the discovery of Pemphigus antibodies, binding of IgG to BMZ was shown in Pemphigoid. And Dr. Beutner and his colleagues in Europe, including Dr. Trzalski and Dr. Jablonska, made significant contributions in the field of immunodermatology. And many of his discoveries resulted in the development of new diagnostic tests for blistering diseases. And we will be discussing some of these tests today. So this diagram here shows the target antigens in various autoimmune blistering diseases. As Dr. Sinha also mentioned, different antigens involved in different groups of diseases. So the binding of autoantibodies to one or more of these proteins leads to disruption of the integrity of the epidermis or the dermo-epidermal junctional area. So great progress has been made in understanding the pathogenesis of AIBDs and also in the development of tests for disease-specific and accurate diagnosis. There are commercially available tests for autoantigens like desmoglein 1, desmoglein 3, BP180, BP230, type 7 collagen, laminin 332, but tests for other autoantigens such as desmoplakins, desmocolins, beta-4 integrin, and laminin gamma 1, and also tests for IgA autoantibodies are available in research labs only. So the reason I put this slide up was to remind us all that there is work that still needs to be done in the diagnostics of these diseases. For the diagnosis of autoimmune bullous diseases, besides clinical and histopathological examination, it is necessary to demonstrate the presence of tissue-bound immunoglobulins or complement and circulating autoantibodies. So the tissue-bound immunoglobulins can be detected by direct immunofluorescence tests on a skin or mucosa. And for this, cryosections of snap frozen biopsy specimen are treated with a primary antibody labeled with a fluorophore, usually FITC. And these antibodies bind to the in vivo or tissue-bound immune deposits. And this reaction can be detected with epifluorescence microscope for its pattern and intensity. DIF is still considered the gold standard, and it can give us an accurate diagnosis if the following parameters are used. What is the primary site of immune deposition? Is it the epidermis or the dermo-epidermal junction or dermal papillae? What is the immunoglobulin isotype? Is it IgG, IgA, IgM, or complement? And sometimes you can see fibrin. What is the pattern of deposits? Is it linear, granular, or fibrillar? Are there multiple immune deposits? And if yes, what is the identity of the most intense deposits? Also, deposition in other sites besides the main site should be looked at, and we will discuss this later. The sensitivity of DIF is greatly influenced by the biopsy site. The ideal site for the biopsy specimen depends on the autoimmune disease that needs to be ruled out. Sometimes multiple biopsies may be needed. It is important not to take the biopsy from the center or the base of the lesion because inflammation can lead to false negative results. At least a 3 to 4 millimeter punch should be taken because this is usually enough even to detect focal deposits. And biopsy should not be cut in half if both DIF and HNE are needed, because the pressure of cutting can sometimes lead to artifacts and make the biopsies hard to read by DIF. And Michel's medium is the ideal medium used for transporting the specimens. The biopsies can be snap frozen in liquid nitrogen and or put in normal saline for up to 24 hours. Do not use formalin for transport specimens for DIF. So this is because we ran a study at Boytner Labs where we examined positive DIF positive specimens by immersing them in formalin at different time intervals. And we found that biopsies that were positive for Pemphigus vulgaris begin to lose immunoreactants within 2 minutes. And the biopsies that were positive for BP and DH began to lose immunoreactants within 10 minutes. And besides that, a non-immunogenic nuclear fluorochroming like that we see in vivo ANA in lupus was observed. So you'll probably end up giving a false positive DIF result. So these diagrams here show the biopsy sites we recommend at Boyton Labs for ruling out all forms of pemphigus and pemphigoid. Generally, 2 biopsies are recommended, one from the edge of a fresh lesion and one from a clinically normal looking area about 3 millimeters away from the lesion. This is especially important in lesions in the mouth because secondary changes can sometimes lead to degradation of immunoglobulins and hence a negative DIF. However, if oral lichen planus needs to be ruled out, then lesional biopsy, lesional site is the best. So it's a combination of both normal and lesional biopsies that's indicated for mouth lesions. And also similarly in dermatitis herpetiformis, a normal area is the best because 10 to 15% of biopsies from lesional area will give negative direct immunofluorescence findings. So besides DIF, serological assays help to demonstrate circulating autoantibodies, as well as they give us information on the autoreactive antigen involved. And the two most commonly used methods, as mentioned by Dr. Sinha as well, are indirect immunofluorescence and ELISA. For indirect immunofluorescence, or IIF, as I will refer to it from now on, it can be done on multiple substrates, and substrates like monkey esophagus, normal and split skin, rat bladder epithelium, and guinea pig esophagus have been used. The sensitivity of various substrates varies for different AIBDs, and these substrates can be used for a detection of IgG, IgG4, and IgA circulating antibodies, as well as plaque antibodies, which can be done on rat bladder epithelium. ELISAs are commercially available for some, but not all AIBDs. And for AIBDs where there are no ELISAs, immunoblots are done in research settings only. So as Dr. Sinha mentioned, AIBDs are categorized into two major groups, the Pemphigus group, where we see intraepidermal blisters, and the Pemphigoid group, where we see subepidermal blisters. DIF and serology by indirect immunofluorescence and ELISA is indicated to correctly diagnose disease in both these groups. The selection of substrate for IIF depends upon the clinical diagnosis and also the findings on DIF and histology. For example, in the Pemphigus group, IIF on monkey esophagus would be the best, followed by ELISA for desmoglein 1 and 3 antibodies. If paraneoplastic pemphigus is suspected, then IIF on rat bladder needs to be added, and also ELISA for endoplakin antibodies. Similarly, in the Pemphigoid group, if IIF shows reaction on the roof of the salt split skin, then ELISAs for BP180 and 230 antibodies is indicated. And if it shows reaction on the floor, then ELISA for type 7 collagen antibodies and IFA test for lambda 332 would be indicated. So what does DIF look like in intraepidermal bullous diseases? As Dr. Sinha showed a very nice picture of chicken-wire and pattern, it's characteristic in all forms of Pemphigus vulgaris and Pemphigus foliaceus. So intercellular deposits or epidermal cell surface deposits are seen because of binding of autoantibodies to the desmosomal proteins in the intercellular space. In most cases, IgG is seen. Sometimes weak focal C3 deposits can also be seen. And granular pattern can sometimes be seen as well. And at Voigtner Labs, we also test for IgG4 subclass because it makes the test more sensitive, especially in lesional biopsies where IgG may sometimes be very weak and focal. And since the deposits are transepidermal, are present throughout the epidermis, DIF should not be used for differentiating between Pemphigus vulgaris and Pemphigus foliaceus. Variable intensities have been reported, like the intensity of deposits is stronger in superficial layers for PF, and it's throughout in Pemphigus vulgaris. But we recommend doing serology for DSG1 and DSG3 antibodies to make this differentiation. Sometimes a mix of IC and BMZ, or the dermoepidermal junctional deposits, can be seen. And this is seen in two settings, one in Pemphigus erythematosus, which is immunopathologically a mix of PF and lupus erythematosus. So we will see characteristic Pemphigus deposits in the epidermis and granular deposits in the junction, which are indicative of lupus band. Also in paraneoplastic pemphigus, we can see a mix of epidermal and basement membrane zone deposits of either IgG or C3 or both. And also we've noticed while we test for subclasses that IgG1 subclass is stronger than IgG4 in PNP. If instead of IgG, you see IgA deposits in the epidermis, that suggests a diagnosis of IgA pemphigus. And as Dr. Sinha explained, it can be of two types, superficial type called subcorneal pustular dermatosis, or it could be intraepidermal neutrophilic type, where deposits will be seen throughout the epidermis. The sensitivity of DIF for pemphigus ranges between 90% to 100%, and the positive predictive value is 100%. False negative results can sometimes be seen if a biopsy is collected from an inflamed area or from the base of a blister, or if there are technical errors. sometimes if the tissue is inadequate and the deposits are focal, we may miss them, so a repeat biopsy is advised. Or if the biopsy has been placed in formalin and then transferred into Michelle's before being sent to a lab. Sometimes drug-induced pemphigus and PNP can also be negative for DIF. PNP because of extreme necrosis in the tissue and lichenoid changes. And in this case, a repeat DIF and also serology is indicated. So these photos here show direct immunofluorescence findings on skin biopsies we received at Boynton Labs, and figure A showing the IgG deposits, which are continuous in the epidermis. And this is IgG4, which is, we can see, much stronger and intense than IgG. And this figure here shows a weak granular intercellular deposits in the epidermis. Another example of DIF on mucosa for ruling out pemphigus. Here we can see both weak intercellular as well as BMZ deposits, which makes it very suspicious for PNP. Coming to the serological diagnosis of PV and PF. So the serological diagnosis can be done using indirect immunofluorescence on monkey esophagus and guinea pig esophagus, or sometimes some labs also use a normal human skin. Now, each substrate has variable amounts of desmoglein 1 and 3, so the sensitivity is influenced by that. For example, a monkey esophagus is more sensitive for ruling out Pemphigus vulgaris, whereas guinea pig is more sensitive for ruling out PF. And sensitivity can be enhanced by using multiple substrates. Overall, the sensitivity ranges from between 70 to 95%. And at BL, we use only monkey esophagus, and we've also added IgG4 subclass on IIF, which improves the sensitivity of this test. And ELISA is available for DSG1 and DSG3 antibodies to confirm the diagnosis and also to differentiate between PV and PF. So if a serum is positive for DSG1 only, it suggests a diagnosis of Pemphigus foliaceus. If it's positive for DSG3 only, then it's indicative of a diagnosis of PV. If both DSG1 and DSG3 antibodies are present, then it indicates a mucocutaneous form of Pemphigus. However, the final diagnosis should be made based on clinical findings as well as histopathology correlated with ELISA findings. ELISAs can also be used for monitoring the disease activity. However, the values may not correlate with disease activity, especially when compared between patients. High index values have been seen in patients in clinical remission. So this photo shows the IgG-IC reaction pattern on monkey esophagus epithelium in a pemphigus patient. So as Dr. Sinha also mentioned, there are a couple commercially available DSG1 and DSG3 ELISAs, and one of them is from Euroimmune. So their ELISA offers a qualitative and semi-quantitative determination of DSG1 and DSG3 antibodies in separate kits. And the results can be analyzed by ratio analysis or 3-point calibrated analysis. Both these ELISAs contain extracellular domains of DSG1, and these antigens are recombinantly produced in human cell line, unlike the baculovirus systems which were used originally. So this system gives a higher yield of mature protein compared to the pro-protein, and the pathogenic antibodies are known to bind better to the mature protein, thereby making the test more sensitive and also specific. Also, this allows the authentic protein folding as well as post-translational modification. And the sensitivity of DSG1 ELISA for PF is 96% and specificity about 99%. And for DSG3, for ruling out pemphigus, it is 100% and specificity 99%. So we compared the results of Euroimmune DSG1 and DSG3 at Boynton Labs with another commercially available ELISA. In this small study, we included 4 groups of sera. The first group was from sera that were IIF positive and DSG1 and or DSG3 positive. The second group included sera with IIF positive and DSG1 and 3 negative with another test. And the third group was where both IIF and DHG1 and DHG3 were negative. The fourth group was sera which were IIF negative and DHG1 and or 3 positive or indeterminate. So the results with Euroimmune, DHG1, and DHG3 ELISA were consistent with the other ELISA in the first three groups. In the fourth group, 3 sera that were positive with the other available tests were negative by Euroimmune ELISA. So since we did not have information on DIF or histology in this group, we do not know if these results were more specific or they were false negative. But we found this test to be cost and time effective and sensitive, as well as specific for use in diagnosis of pemphigus. So this is an overview of the sensitivity and specificity of all the diagnostic tests that are available for various forms of pemphigus. I apologize for this busy slide. I promise I'm not going to say out all these numbers, but just to get this gist or the summary, we could say that DIF and serology are needed for making an accurate and correct diagnosis of these diseases. For IgA pemphigus, our best bet is direct immunofluorescence because the indirect immunofluorescence does not have a great sensitivity for IgA antibodies. Also, we do not have commercially available ELISAs for desmocollin IgA antibodies or for desmoglein IgA antibodies. The next few minutes, I would like to share our experience on the use of a new commercially available endoplakin antibodies ELISA for the diagnosis of paraneoplastic pemphigus. It's important to diagnose this condition because of its association with malignancies. And paraneoplastic pemphigus, or PNP, as Dr. Sinha mentioned, is an autoimmune disorder linked to an underlying lymphoproliferative disorder. It was first described by Dr. Anhalt in 1990 as an autoimmune entity distinct from Pemphigus vulgaris because it had autoantibodies to other antigens besides desmoglein 1 and 3. It has a strong association with hematological disorders, which account for about 84% cases. So non-hematological neoplasms are seen in some cases. And now because multiple organ involvement is seen and there's a lot of clinical phenotypes, as Dr. Sinha mentioned, the term paraneoplastic autoimmune multi-organ syndrome, or PAMS, has been proposed. So the clinical feature can be variable, and also the histology, which can show a mix of acantholysis and lichenoid or interface changes. Direct immunofluorescence, as I showed an image of a photo before, can be a combination of epidermal and BNZ deposits. The striking feature here is the autoantibodies to multiple autoantigens, which is also known as the paraneoplastic pemphigus complex. So we can have autoantibodies to desmoglein 1, desmoglein 3, desmoplakin 1, 2, BP pemphigoid, BP antigen 1, envoplakin, periplakin, plectin, and alpha-2 macroglobulin like 1 protease inhibitor. Some patients may not demonstrate antibodies to proteins in this complex. So the diagnosis of PNP should include demonstration of anti-plakin antibodies. This can be done using indirect immunofluorescence on rat bladder epithelium because it is rich in plakin antibodies, plakin antigen. And the sensitivity of this test ranges from 66% to 86%, and specificity has been reported to be between 83% to 99%. So due to their high specificity, anti-plakin antibodies are considered an important diagnostic marker for PNP. So we did a small study at Boydner Labs to determine the clinical sensitivity and specificity of a newly developed anti-envoplakin ELISA by Euroimmune. So I just want to show this image of rat bladder epithelium. This is positive for paraneoplastic pemphigus antibodies, and this is a control here, which is completely dark. So for this study for envoplakin ELISA, we used retrospective serum samples from that were submitted to the lab with clinical suspicion of PNP, and sera from 16 patients who fulfill the diagnostic criteria of rat bladder positivity by IIF and or clinical presentation were analyzed. An anti-endoplakin ELISA was performed along with repeat of IIF on rat bladder. The control group included sera from patients with pemphigus foliaceus and vulgaris, then also dermatitis herpetiformis, bullous pemphigoid, and other autoimmune diseases and infectious diseases. Asymptomatic blood donors were also included. The ELISA was performed as per the instructions given in the kit, and the results were calculated using a ratio analysis. A ratio of less than 1 was considered negative, and a ratio of more than or equal to 1 was considered positive. For determining the precision and reproducibility of this test, a representative set of 4 serum samples were run on this test, and samples were tested in triplicate and repeated on 3 different days with 2 different lots. And this table here shows the results of anti-endoplakin antibodies in sera from PNP patients and controls. 12 out of 16 patients were positive, giving a sensitivity of 75%. And only 1 patient in the pemphigus group gave a positive result. None of the other controls were positive. This gave us a specificity of 97%. The concordance rate for inter-run and intra-run was 100% using the 4 sera tested in triplicate using 2 different lots on 3 consecutive days, and these are the results here. So we concluded that this Euroimmune endoplakin ELISA fulfilled all the validation parameters. It was 75% sensitive, and the specificity was 97%. The concordance agreement of the qualitative results for inter-run and intra-run was 100%. This is a much easier test to perform compared to immunoblot for endoplakin antibodies, and therefore it appears to be a useful diagnostic tool to confirm a diagnosis of PNP. So up next is the diagnosis of subepidermal bullous diseases. So as Dr. Sinha mentioned, this group is comprised of diseases that exhibit antibodies to BMZ antigens or the dermo-epidermal junction area antigens. It's a heterogeneous group comprising of bullous pemphigoid, mucous membrane pemphigoid, ocular pemphigoid, pemphigoid gestationis or gestational pemphigoid, epidermal lysis bullosa acquisita, bullous lupus erythematosus, laminin 332 autoimmunity, which was previously known as epiligrin autoimmunity, the laminin gamma 1 autoimmunity, also known as P200, linear IgA bullous dermatosis, and dermatitis herpetiformis. So DIF remains the gold standard and the first step in the lab diagnosis of this group of diseases. The isotype of the immunoglobulin and the presence of multiple or single immune deposits and the pattern should be considered when we want to diagnose this group of diseases. So these images show that in this group of subepidermal bullous diseases, linear deposits of IgG or C3 are seen in the dermo-epidermal junctional area. And in bullous pemphigoid, it's usually IgG and or C3. Multiple immune deposits can be seen, but the intensity of IgA and IgM is usually much less compared to that seen with G and C3. And however, in EBA, we can see multiple immune deposits. And this is an example of mucosa, which is positive for IgG. It's lighting up on the epithelial roof. However, this plane of cleavage may be artifactual, and we do need to do serology studies to rule out whether it is deposits on the roof or the floor. And here's an example of ocular pemphigoid, where we can see IgG deposits in the junctional area. So one of the methods to determine the localization of immune deposits in the skin is direct immunofluorescence on the salt split skin biopsy specimen. So this test can be performed on biopsies that have no pre-existing separation or microvesicles, and they're positive in primary DIF studies. So in this case, DIF was positive for IgG4 in a normal-looking biopsy specimen. So this specimen was placed in normal saline for 24 hours, then taken out and processed again for IgG4 by DIF. And this revealed immune deposits on the epidermal roof, indicative of lamina lucida type of autoimmune blistering disease, or the bullous pemphigoid group. And these images reveal deposits on the floor. This is IgG, G4, and IgA. And these are the images from normal skin of this specimen. So this is indicative of EBA group or bullous LE or laminin 332 or laminin gamma 1 autoimmunity. Sometimes deposits in areas other than the dermal epidermal junction can be observed. In this case, we see in vivo ANA deposits in the epidermis, along with weak positive BMZ deposits. So such findings may point to a diagnosis of bullous lupus erythematosus. However, tests for type 7 collagen antibodies and clinical correlation is indicated to determine or confirm this diagnosis. So if instead of IgG, we see linear deposits of IgA, it's suggestive of linear IgA bullous dermatosis. And DIF is positive in 80 to 100% cases of LABD. Linear IgA bullous dermatosis can be drug-induced or it may be idiopathic. And the target antigen has been reported to be LAD97 and LAD1. Both these are ectodomains of BP180. And IgA antibodies to type 7 collagen have also been reported. So this figure here shows granular deposits of IgA in the dermo-epidermal junction and also in the tips of dermal papillae. So this is consistent of a disease known as dermatitis herpetiformis, which is associated with gluten-sensitive enteropathy. And patients with DH produce IgA antibodies to tissue transglutaminase, and epidermal transglutaminase is supposed to be DH specific. So next is serological diagnosis and differentiation of subepidermal bullous diseases. Serology is an important component of the diagnostic workup of subepidermal bullous diseases. It helps to confirm the diagnosis as well as differentiate various forms of SIBDs because DIF is very similar in this group of diseases. Conventionally, serum tests follow a multi-step approach. The initial screening is done by IIF on monkey esophagus or on normal human skin. And at Beutner Labs, we start with IIF on monkey esophagus to determine the presence of BMZ antibodies and also the titer of BMZ antibodies. And IIF on split skin is also done. So if positive on the epidermal roof, then ELISA for BP180 and BP230s is done. If IIF on split skin is positive on the dermal floor, then ELISA for type 7 collagen antibodies is done. So if this test is negative, then it probably indicates that it could be laminin 332 autoimmunity or laminin gamma 1 autoimmunity. And a test for laminin 332 autoantibodies became recently available from Euroimmune in an IFA format. So these photos here show us reactions on the epidermal roof of salt split by indirect immunofluorescence. And this is the reaction on the floor. So depending on what we see with this test, a follow-up ELISA tests are done. So this algorithm shows a multi-step approach that can be followed to diagnose IgG and C3-mediated subepidermal blistering diseases. And DIF gives us a preliminary diagnosis. And this test is 95 to 100% sensitive in diagnosis BP, gestational pemphigoid, and EBA group. And however, all positive and negative cases where clinical suspicion is high should be followed up by serology on normal and salt split skin. And subsequently follow-up studies depending on the findings on this test, because this will give us a disease-specific diagnosis. And however, for gestational pemphigoid, IIF on split skin or monkey esophagus is not very sensitive. Anti-BP180 ELISA gives us a better sensitivity. Similarly, not all patients with EBA will reveal antibodies by indirect immunofluorescence, and anti-collagen 7 ELISA or IFA test for these antibodies became recently available, and it has reported a variable sensitivity ranging from 45% to 98%. Again, a very busy slide. I'm not going to say all these numbers here, but the take home is that it's a combination of DIF and serology, which helps in confirming and giving us an accurate diagnosis for subepidermal blistering diseases. I'm going to talk a little bit about BP 180 and 230 ELISA and their use in monitoring the disease activity. So high baseline indices of BP 180 have been linked to disease relapse and also a more severe disease. So they have been, this ELISA has been used to monitor disease activity. However, this test should not be used as a standalone test for diagnosis, and it has a sensitivity ranging from 53% to 95%. A combination of both BP 180 and 230 gives us a better sensitivity. So what are some of the advances made in serological diagnosis of autoimmune bullous diseases? So newer technologies have been developed to improve the diagnostic efficiency and accuracy. These include IFA on monospecific recombinant substrates, and this is based on biochip technology from Euroimmune. This test allows the testing of multiple samples and substrate biochips slides under standardized and identical conditions. And two types of recombinant substrates have been used in this IFA. Target antigens expressed in human cell line and purified recombinant antigens, which are coded directly onto the biochips. And these tests, this test is easy to perform, and it has high sensitivity and specificity compared to the conventional methods for Pemphigus and Pemphigoid. So this slide here shows one, highlights one well where we can see multiple antigens coded here. So obviously, when you put the serum onto this well, it will pick up autoantibodies to multiple antigens. So I got this image from a report published by Sandra S. et al. And this shows the detection and differentiation of autoantibodies and AIBDs using monospecific substrates for biochip-based IFA. Like well, A is DSG1, this is DSG3, and C is our BP230, and D is type 7 collagen, and this is BP180. So we can see that multiple autoantigens can be detected in one test. And this figure G is actually IIF for laminin 332 on autoantibodies on transfected cells that we tested here at Boytner Labs. And this test is being validated at our lab. It's not FDA approved yet. Similar to the concept of biochip IFA, multivariant or multiplex ELISA systems are not now available. So antigens like DSG1, DSG3, BP180, BP230, type 7 collagen, and envoplakin are coded in adjacent wells, allowing simultaneous testing for many AIBDs in one assay, thus saving time. And this may also be helpful in detecting epitope spreading, which sometimes happens during the disease course in these patients. And concordance with individual ELISAs is reported to be 87 to 88% with comparative sensitivities with individual ELISAs. Also, chemiluminescent enzyme immunoassays are now available. I think I will stop here by concluding that the diagnosis of AIBD is based on a combination of clinical exam, histology, DIF studies, which remains a gold standard, but it gives us limited information on target antigens in some diseases. And therefore, serological detection and differentiation of circulating antibodies and for disease monitoring in some cases is indicated. Also, advancements in the understanding of these diseases and availability of newer serological tests has made it possible to provide us with a specific diagnosis of these diseases. And hence, continued research and development of serological assays for known antigens as well as unknown antigens is important. So thank you all for being here today and for your time. Please feel free to type any questions you have in the chat box. Thank you again.
Thank you so much, Dr. Grover, for talking about the different immunofluorescence testing available for AIBDs and also addressing the advantages for serological testing. I will now pass it over to Ilana.
Hello, everyone, and thank you for all of your questions during both of the talks. We're going to get started with the question and answer session. I just wanted to mention, because there were quite a few questions, that any questions we do not get to during the live session will be answered via email in the coming week. So the first question I will direct to Dr. Sinha. The question is, can the deficiency of certain vitamins or minerals possibly worsen autoimmune bullous diseases?
So it's a really good question regarding vitamins, and I'll lump it in with food as well, because I think that was another question. There are anecdotal reports about various foods, worsening or triggering autoimmunity or the blistering disorders and vitamins, etc. There's no definitive information and scientific evidence as far as I know. I'll put it in this context. We know these diseases are multifactorial, so there are genetic factors. We know some of the key immune genes, but most of the genes we don't know. And we have very little idea of the environmental triggers. It's clear that environmental triggers are important. And what I mean by environmental factors includes infections, stress, our nutrition, etc. There are some foods that have been thought to exacerbate existing lesions, irritating foods, garlic, onions, etc. Not sure that they're triggering necessarily for disease. For vitamins, I think the interesting point there is people often on long-term steroids need replacement with vitamin D and calcium. And I think that's an important fact to keep in mind. But there's not great evidence for food or vitamins triggering disease, but that's work on the environmental factors that are important in disease still needs to be done.
Great. Thank you for your response, Dr. Sinha. The next question I'm going to direct towards Dr. Grover. It was asked, what's the practical importance of detection of IgG and IgG4?
So in our experience, we found that both in direct immunofluorescence and indirect immunofluorescence, addition of IgG4 tests improves the sensitivity of the test. We've seen examples here, especially for mucosal biopsies, DIF, where IgG4 may not be seen G may not be seen very well, and we may end up calling a biopsy iffy and ask for another biopsy. But if we test for G4, it lights up, and this helps us in making the diagnosis. And also for IgG4, it gives us good reactions and better titers in patients who may not have high titer of IgG antibodies.
Thank you, Dr. Grover. Now I'll move over to a treatment question. So this is for possibly Dr. Sinha to answer, is there a role for GI microbiome manipulation in the treatment of autoimmune bullous diseases?
Right. Really also a great question. A lot of attention has been put on the microbiome in recent years. We're learning so much more about its role in health and disease, including autoimmune diseases. There's been suggestions about manipulating the microbiome to help tip the balance away from autoimmunity. For the blistering disorders, as far as I know, that there's not enough knowledge yet. We know about the differences in microbiome that are linked to disease. I think it's an area that needs to be more fully explored and investigated. I think, again, in the context of these diseases being multifactorial, there's no doubt our microbiome does impact the immune system, and there's no reason to think it wouldn't impact our autoimmune responses as well. We just haven't done the studies or have the data to be, very definitive about the role of the microbiome and the potential manipulation of the microbiome in this clinical setting.
Thank you. Another question for you, Dr. Sinha. what is the prevalence of drug-induced pemphigus slash pemphigoid versus non-drug-induced autoimmune bullous diseases, and how easily can these be distinguished, and how easy is it to find the culprit drug?
Okay, sure. So drug-induced pemphigus and pemphigoid do occur. They're more rare than compared to the other forms of or etiologies of pemphigus, which are probably just require a genetic predisposition and some other triggering factors. Probably in drug-induced pemphigus, there's also genetic predisposition, but in this case, there's a direct triggering from a drug. The mechanism of that is, again, unclear. Could it be a immune reaction to the drug that cross-reacts with the pemphigus and pemphigoid antigenic targets, or some more indirect impact on the immune system? It's not clear. The clinical presentation is pretty much identical. I don't think there's a way to distinguish it, except that maybe in drug-induced pemphigus, it's more likely to be on the trunk versus oral, but in drug-induced pemphigoid, more likely to be in younger patients than in regular pemphigoid. A number of different drugs have been implicated: the thiol drugs in Pemphigus vulgaris, certain antibiotics like the penicillin, cephalosporin, ACE inhibitors like captopril, lisinopril, even some topical medications like imiquimod, Aldera, and neomycin, bacitracin. For pemphigoid, Enbrel or etanercept, it's an anti-TNF molecule that's been implicated. Lasix or furosemide, a diuretic, penicillin, again, some ACE inhibitors. So there are a number of candidates. I think there are over 50 drug candidates that have been, in case reports, et cetera. It's hard to directly prove it, but withdrawal of medication and improvement of symptoms can be somewhat correlative. Very interesting clinical entities. Hard to do controlled studies on these, but we have a lot of case reports that suggest that it certainly does exist.
Thank you. I'll pass it over now to Dr. Grover to answer this question. So it was asked for immunofluorescence. Do you use a neutralizing agent to avoid human isoglutinins? And if yes, is it for each serum?
So we do not do that, but I believe that slides that we use have been absorbed with, antigens to prevent this. So, and also, we sometimes see non-specific IFA, especially in intercellular reaction pattern when there are blood group antibodies reacting with antigens on monkey esophagus epithelium. And that is, you have to definitely do DSG1 and DSG3 ELISA. And sometimes you can also see blood vessels lighting up. So we give that, we generally report that as blood vessel antibodies, and indicating that DSG1 and DSG3 ELISA are needed for confirmation.
Thank you. A follow-up question for you, Dr. Grover. It was asked, could ELISA for DSG1 and DSG3 replace immunofluorescence for the diagnosis of pemphigus?
Great question. So from what I think, IFA is a catch-all, because sometimes you think it's pemphigus, but it turns out to be pemphigoid. So you should do IIF. And also the desmoglein 1 and 3 ELISAs that are available right now include certain domains of the antigen. It's not the complete molecule. And you never know, there may be patients who may have autoreactive epitopes or areas outside those domains. So, and Dr. Sinha is doing an extensive work and research on this to find out non-DSG1 and DSG3 antigens in pemphigus. So, of course, I think IIF still should be done, and ELISA is the confirmation.
Great, thanks. Okay, so now a question for Dr. Sinha. It was asked, will multiplex arrays, such as the biochip technology, become part of the diagnostic guidelines, do you think?
I think, we're in a phase where we are developing newer and multiplex and more rapid and accurate tests. I think over the years, over the coming years, while we have our gold standards of, indirect immunofluorescence right now, I do think there'll be a time in the coming years where we are able to incorporate multiplexed assays that will comprehensively look at across autoimmune bullous disorders, across multiple antigens and epitopes, and be done so in a rapid fashion to track individual patients. And Dr. Grover and I have made discussions on this and have some research projects aimed at those goals. So I think over the next few years, you'll start to see the continued evolution of these multiplex assays. And then we have to see how accurate they are, how useful they are in the clinical setting, and how cost effective they are. But I think that's the course that we're headed on.
Awesome, thanks. This is a question that could possibly be answered by either speaker. It was asked, how are you able to detect possible overlapping autoimmune bullous diseases?
I can start again. Similar to the last question, I think it's a great question and thought that, again, while we push the envelope in terms of diagnostic tests, and sometimes where it's not easy to make the diagnosis clinically, Dr. Grover and I again have discussed envisioning platforms that would look across multiple autoimmune blistering disorders that we could, in one fell swoop, differentiate between clinical entities that may be similar.
Great, thank you. A question now for Dr. Grover. It was asked, do you have experience in bulbous pemphigoid DIF with IgE deposition?
Yes, we have started running that test on all our positive BP biopsies, but I haven't seen anything positive yet. So I'm waiting, probably because the half-life of IgA is so less that we may be missing out because of biopsies being in Michelle's for over 3 to 4 days, but we haven't had any luck yet. But we are trying, and we test all our BP positives with IgA. We don't report it, obviously.
Thank you. We have time for a few more questions. I'll ask Dr. Sinha now. Have you ever treated your patients with anti-IgE for bullous pemphigoid?
I haven't, but it is a good point because the inflammatory and the itch component is so important. There were some clinical trials and some on anti-eosinophilic molecules, and I think anti-IgE therapy. So I do think that it should be in consideration, especially for patients with a lot of itch.
Thank you. A few more questions. So for Dr. Grover, it was asked, could immunoblot be used as a confirmatory test in cases of a positive ELISA?
Yes, it could be if you are able to run it. We are standardizing immunoblot for periplakin and endoplakin and for paraneoplastic pemphigus, but there are immunoblots available in other research labs.
Okay. Just maybe one or two more questions. For Dr. Grover, someone asks that, or comments that in Japan, chemiluminescence enzyme immunoassays are also used for serological confirmation, and wants to know if this sort of assay is also used or known in the US.
So we've heard about it, and I don't think they are FDA approved yet. So if they would be, then definitely they could be added to the testing we do.
Okay, so I'll possibly just ask one more question. This one for Dr. Grover. Actually, sorry, this one's probably more towards Dr. Sinha. It's asked, what is your experience with, I believe the brand name is Xolair for refractory bullous pemphigoid?
Right. So also for knocking down the inflammatory response and IgE. So I haven't used it much, but I think it is, as I said, it should be in consideration. And so bullous pemphigoid has a lot more of an inflammatory component to it than Pemphigus vulgaris. And so in addition to knocking down the antibody production, anti-inflammatory therapies, anti-itch therapies, anti-IgE, and anti-eosinophilic therapies are being explored.
Thank you so much, both Dr. Grover and Dr. Sinha, for responding to all of these questions. We do have a few more that will be just answered because we're a little bit over time via email, so look out for that. And with that, we've reached now the end of the Q&A session and the end of the webinar. So I want to thank everyone for attending today, and also mention that if you are interested in receiving PACE credits for your attendance today, look out for an email, a follow-up email from the Autoimmune Academy, where we will provide some instructions on how to obtain your PACE credits. And we look forward to seeing you at future webinars. So look for emails for future invitations there. And have a great day, everybody.
Thank you.